All right. Well, good evening, everybody, and thank you for taking the time to join us for our educational health webinar on our treatments for hemorrhoids, BPH, and knee osteoarthritis. Chesapeake Urology is excited to offer these new minimally invasive treatment options in our office-based angio suite, which is located at the Towson Town Center. I am honored this evening to introduce our presenter, Dr. Abid Razvi. You can advance the slide. So Dr. Razvi is a board-certified vascular and interventional radiologist at the IR Centers of Chesapeake Urology in Towson. He graduated from George Washington University School of Medicine before completing residency at Penn State University Hershey Medical Center in diagnostic radiology. Dr. Razvi then completed his subspecialty training in vascular and interventional radiology at Penn State University. After graduating in 2019, he took a staff position at Penn State as an interventional radiologist, where he served as the medical director of the radiology procedure suite. He joined Chesapeake Urology in 2022 with special interest in prostate artery embolization for the treatment of BPH and large prostate, as well as minimally invasive treatment of hemorrhoids, varicoceles, uterine fibroids, pelvic congestion, and musculoskeletal pain. So without further ado, I present to you Dr. Abid Razvi.
Thank you, Marco, and thank you everyone for joining us for tonight's webinar to discuss some of the exciting new services we're offering at our clinic called the IR Center at Chesapeake Urology. I'm Dr. Razvi, as Marco said, and I'm a vascular and interventional radiologist. That's what the IR and IR Center stands for. And a lot of people don't really know or understand what IR is. So I wanted to go through that a little bit just so everyone has an understanding of what it is and what kinds of therapies we can do. So interventional radiology, it's a subspecialty of medicine, specifically of radiology, which utilizes minimally invasive image-guided procedures to help diagnose and treat different diseases throughout the body. It's an alternative to traditional open surgery where we can do things in a less invasive fashion through small puncture holes and use imaging guidance to kind of visualize equipment throughout the body. And the whole concept behind this specialty and in these interventional radiology procedures is, again, to use the least invasive techniques in order to minimize risk to the patients and improve overall health outcomes. So these procedures, like I said, are associated with less risk, less pain, and have a faster overall recovery time compared to more traditional open surgeries. Now, interventional radiology, it can address things all over the body, literally from head to toe. We're able to do various therapies. And again, the whole point of tonight's webinar was to kind of discuss a couple of these therapies that we offer at our center that people can be interested in or may need some help with. But overall, we were able to do a lot of things within the genitourinary system. So we can place tubes into kidneys or bladders. We can treat tumors within the kidney. For men's health, we're able to do treatments for the prostate, as well as varicoceles, which are kind of dilated veins around the testicles. In the GI system, we can treat hemorrhoids. We can treat tumors in the liver, do interventions on the biliary system. There's a lot of new techniques related to musculoskeletal pain, which we'll actually discuss some tonight. So knee pain, shoulder pain or frozen shoulder, joint injections. For women's health, we have treatments available for fibroids, adenomyosis, and pelvic congestion. And we can also just do a lot of other procedures throughout the body within the veins and the arteries and the leg. And so there's a real wide variety of treatment options available through interventional radiology. And again, the way I like to think about it is literally from head to toe, we're able to do these minimally invasive treatments. So a lot of people may be wondering what embolization exactly is. On the prior slide, we saw a lot of words called embolization. So embolization, it's a minimally invasive procedure that blocks or closes off specific blood vessels. And it's typically done by placing a small catheter tube that's about the size of a piece of spaghetti into the blood vessels and using an X-ray machine to then guide them through the pathways of the blood vessels until we get to the specific body part that we're trying to treat. And then I would either use small particles or sometimes it's coils, which you see in the image here, to basically block off the blood flow in those specific blood vessels. And by blocking off those blood vessels, we're able to do various treatments in different parts of the body. So we'll start with some of the treatments we're doing for hemorrhoids and kind of go through that a little bit. So hemorrhoids, they affect 4 to 5% of the population every year, with a peak age distribution of 45 to 65 years old. 10% of patients may require some type of surgical treatment, and there's really no sex preference with hemorrhoids. They can affect men and women equally. Women, especially the younger females, sometimes are a little bit more risk because of that pregnancy risk factor. But as time goes on and later in life, they pretty much affect everybody equally. They were the third most common outpatient GI diagnosis, with nearly 4 million office and emergency room visits annually. So very common. And there can be different degrees of severity for hemorrhoids. So you can see on the left here, there's a grading system that we use. So grade 1 hemorrhoids are those kind of dilated veins that are prominent. They may bleed, but they remain within the rectal cavity. The grade 2 hemorrhoids are those that can prolapse or extend out of the rectal cavity, but they will go back in on their own. The grade 3s extend out of the rectal cavity, but actually need to be pushed back in manually. And then the grade 4s are those that are permanently prolapsed, and even with a manual reduction, they won't go back in. And there are several treatment options available for hemorrhoids. So you can do lifestyle modification. A lot of the gastroenterologists or colorectal surgeons would do rubber band ligation. There's a therapy called hemorrhoidal artery ligation. There's sclerotherapy. There's a traditional kind of open surgical procedure, which is the hemorrhoidectomy. And then the procedure that we do within the IR center that I do is hemorrhoid artery embolization. And that essentially targets these small blood vessels that supply the rectal area called the corpus cavernosum recti. So there are several risk factors that can lead to hemorrhoids. Anything that increases pressure within the abdomen can lead to hemorrhoids. So again, that's why younger females are at risk for this. Pregnancy, there's obviously a lot of increased pressure within the abdomen when you have, a growing baby and a growing uterus in there. But even cirrhotic patients can also be predisposed to developing hemorrhoids just because of the pressure within the abdomen. Having poor bowel habits, so straining or sitting too long on the toilet. This meme was meant to be a joke, but I think we're all guilty of spending too much time in there, scrolling on our phones. We tend to lose track of how long we've been in there, but that's actually one of the biggest risk factors for developing hemorrhoids is just sitting too long. Being constipated or having diarrhea can cause hemorrhoids. A low fiber diet with insufficient fluid intake, obesity, or a sedentary lifestyle. And there's even a lot of time a genetic component as well, where if you had a parent or a grandparent that had issues with hemorrhoids, then a lot of times that's what is the reason that you have problems with hemorrhoids as well. Now, there are several options available for treatment, and most of the time, the first line therapy is some sort of a conservative option or a medical option. So just adjusting your diet, increasing the fiber, and avoiding junk food, increasing fluid intake, doing things to avoid constipation. So taking some stool softeners or low dose laxatives, and then again, not spending too long on the toilet. So finishing what you need to do and then getting up and leaving the bathroom is one of the best things that can be done as well. There's other comfort measures, doing things like sitz baths, using a preparation H or a topical steroid can help reduce some of the inflammation associated with steroids, but they only work short term. And if you continue to use them for too long, then it can cause thinning of the skin. And then a lot of people will sometimes want to wash very aggressively with soap. That's actually can be counterintuitive. It can dry the area and actually make symptoms worse over time. Now, when conservative measures don't work, the next thing that people look into are procedural options. So some of the non-surgical treatments that, I mentioned before that a gastroenterologist or a colorectal surgeon can be rubber band ligation, where they go in through the rectum, kind of grab the hemorrhoid and place a rubber band around it to essentially kind of starve it away. There's something called Doppler guided ligation, which is kind of the bottom two images you see here, where they identify the blood vessel that supplies the hemorrhoidal area, and this is done from inside the rectum, and then to kind of throw a stitch around it to try to cut off the blood supply to the area. And that's kind of the precursor to why this embolization technique works, which I'll show you in just a little bit. Some of the surgical options that I mentioned before is the excisional hemorrhoidectomy, where they actually go in and cut out the hemorrhoid. It's a 90% success rate with that procedure, but it's associated with severe post-op pain and a very long recovery time. I've had some patients that have had this procedure done before they come to me for the hemorrhoid artery embolization, and it's very common that I'll hear from patients that it was the worst experience they went through, the worst pain, and probably the hardest recovery they've ever had. But that is one of the options for treatment as well. So why is it that this new technique, hemorrhoid artery embolization, is so important? Well, 50% of Americans suffer from hemorrhoids by the age of 50. And I would even argue that that number is probably underestimated. There's an old saying that there's two types of people. There's people that have hemorrhoids and those that deny them. So, for reasons of embarrassment or shame, sometimes people are not as open about having them or having issues with them. So I would argue that 50% is probably even a bit on the lower side. And then those that do go on to get treatment, just about half of them will have recurrence of symptoms or new hemorrhoids develop even after getting treatment. So if we can find newer or better techniques that are more effective and have a quicker recovery time for patients, then I think that's a great thing for patients. So embolization has been around for a long time. The first embolization was described back in the 1970s in the setting of bleeding. And then Dr. Vidal, which was kind of the pioneer of this particular technique that I'm discussing, kind of described it back in 2015. And since then, several studies were done until about 2020, where we had amassed about 14 clinical trials, which show that there's an 80% success rate with this particular treatment option. So the whole concept of this therapy. So on the prior slide, I showed that there's a technique called Doppler guided ligation, where they go through the rectum, they identify the artery or the blood vessel supplying the hemorrhoidal area and tie a stitch around it to kind of choke the hemorrhoid of blood supply. So what Dr. Vidal came up with was that, we can essentially do the same thing from a less invasive standpoint. So using the embolization techniques we've been doing for, 50 plus years at this point, we can essentially guide a small catheter through the network or the passageways of the blood vessels until we get down to the blood vessels of the rectum that you see in this middle picture here. And when those abnormal blood vessels are identified that supply the rectal area, small little coils or these little springs get deployed inside the blood vessel, and that blocks the blood flow and reduces the pressure head going to the area, and will actually shrink the hemorrhoids because it's being starved of blood flow. So who's a candidate for this type of procedure? So, I previously mentioned about the different grades of hemorrhoids. So those with the grade ones who have those prominent vessels, but their symptoms are overall less severe, a lot of times they'll do well with just conservative management. So increasing their fluid intake, increasing fiber in their diet, improving bowel habits. Now, those with higher grade hemorrhoids, the grade 2s and the grade 3s, and even the grade 4s, should all start with those basic conservative therapies. Most of the time, they'll end up failing them and then need to go on to the different procedural options. And basically any technique that we talked about is a potential option for these patients. And eventually, if they need, they can get the hemorrhoid embolization procedure if they fail other therapies, or even as their primary choice if they prefer to have that procedure over some of the other ones that are offered. The grade 4s, they're in a little bit of a special category because at that point the symptoms are so severe that they may have to undergo the hemorrhoidectomy or the surgical procedure. Now, if there's a contraindication to having the surgery, or if there's a strong desire that a patient would not want that surgery, then they can definitely try the other techniques, but they may have a lower success rate compared to the grade 2s and the grade 3s. So how exactly do we do this procedure? So basically what I'll do is I'll find the blood vessel at the top of the leg and insert a small catheter, like I said, about the size of a piece of spaghetti, into that blood vessel. And then I view it on the inside using an X-ray machine and guide that little catheter down to the blood vessels that supply the rectal area. And when I get down close to where the hemorrhoid is, through that little catheter, I'll inject these small little beads that will block up the blood flow. And then lastly, deploy that little coil or that little spring, which plugs up the blood vessels and reduces the blood flow going to the area. And the hemorrhoid will then shrink down in size. It happens a little bit, a little longer over time. In the animation, it shows that it's pretty quick, but it can take a little bit of time for that hemorrhoid to shrink down in size. So the next thing I'd like to talk about is benign prostate hyperplasia, or BPH, which is another area that we can treat at the IR center using a similar technique by going through the blood vessels. So BPH, it affects nearly 20 million men, and 50% of them, of men over 50, have the condition, and 80% over 80 have that condition. And the annual cost is about $3 billion annually in the US. So what happens in BPH is the prostate grows in size. And when it grows, because of, you can see in this middle picture here, the anatomy and the way that the prostate is in relation to the bladder. So when the prostate grows, it kind of pinches off that passageway or for that urine to flow, and it also grows up into the bladder and kind of exerts some pressure on the bladder. And that causes symptoms of feeling like the bladder is not fully emptying, going to the bathroom often, especially waking up at night. You can get the strong urge to urinate or use the bathroom, and the stream of urine can be very weak or like a dribbling while it's coming out. So why is it important to kind of have new techniques for treating the prostate? Well, 15 million men in the US alone suffer from BPH, and over half of them are avoiding other treatment options because of fear of side effects. So a lot of the traditional surgical therapies for BPH is to get to the prostate, a lot of times through the penis, to shave away parts of the prostate. And that can, it can be a long recovery time. It requires placement of a catheter after the surgery. And it can lead to, various sexual dysfunction and potentially urinary incontinence as a result of those procedures. So this newer technique to treat the prostate that's done at the IR center through the blood vessels avoids a lot of those complications. So essentially, similar to what we did for the hemorrhoid treatments, again, I would go through the blood vessels, get a small catheter down to the blood vessels that supply the prostate, and inject these small little beads that plug up the blood vessels, which ultimately starves the prostate of oxygen and nutrients, and it will then shrink down in size. So in this graphic, you can see that the catheter that's delivering those little beads on one side of the prostate, and the other side's been treated already. You can see that it's shrunk down, and by shrinking down, it opens up that passageway for urine to flow, and there's less pressure on the bladder once the prostate shrinks in size. So this is done in a very similar way to the hemorrhoid treatment. So again, that catheter is guided from the top of the leg down into the blood vessels of the pelvis. Specifically, we avoid the bladder and go down to the prostate and deliver this material, which plugs them up. And like I said, starves the prostate of oxygen and nutrients, and it will then shrink down in size. So another area that we can that we have treatments for at the IR center is arthritis, specifically knee arthritis. So arthritis can affect about 30 million people in the US, and the most common site is the knee. the typical thing that people do is they take a lot of pain medication, specifically things like Motrin or Aleve. Basically, these the NSAID class of medications, which are non-steroidal anti-inflammatory drugs. Um, and unfortunately, those medications, although they relieve pain very well, they can have side effects specifically related to the GI system. And we see that there's over 100,000 hospitalizations that are related to some sort of GI toxicity as a result of being on these medications. And over 16,000 NSAID-related deaths in arthritis patients have been reported. Other forms of therapy that patients choose are getting steroid injections of the knee or Synvisc material. And eventually they do this for a while until they can't tolerate the pain anymore, and then they eventually get a knee replacement, which again is a long recovery time and requires a lot of kind of therapy afterwards to get back to a functional status. Now, a lot of the patients that have the steroid injections, as they continue to get them, they realize that they're less and less effective each time. So they might get an injection, and the first time it might last them several months, but then they go on, and their symptoms come back. They get another injection, and it might only last 1 or 2 weeks, a second or a third time around. So the reason why embolization, I mean, you're probably thinking, well, how do bones and joints, how does that relate to, blood vessels or shutting off blood flow in blood vessels? So what we have seen is that, all the joints in the body are lined with a lining called synovium. And in the setting of arthritis, this lining around the joint gets inflamed. And when it gets inflamed, it releases certain cellular factors, and these cellular factors then promote angiogenesis, which is new blood flow. So you get new abnormal blood vessels forming around the joints, and the creation of these blood vessels causes more inflammation. So you get stuck in this cycle, and all of this leads to or contributes to pain, and it just continues on because it just keeps on going in this cycle. So what we've seen is that, again, same way by going inside the blood vessels, we can see that the joints that have arthritis around them, actually you can see that that new formation of the blood vessel. So on the image on the right here, that yellow oval is highlighting areas of abnormal vascularity. So you can see this kind of smudgy appearance, almost like a blush along the lining or the edge of that bone or the knee joint, and that's abnormal. That should not be there. So that shows that this inflammatory process of the arthritis has created these new vessels that should not be there, and that's a big source of what's causing pain in arthritis. So luckily, the same way we've done it for hemorrhoids and the prostate, we can also reduce that abnormal blood flow by performing embolization in the knee. And so again, the way this is done is I'll get into the blood vessel again at the top of the leg with that small catheter. And then using that X-ray machine, I'll see that inside the body, and I'll guide it and navigate it down the blood vessels of the leg until I get down to the blood vessels of the knee. And then I'll specifically advance the catheter into the blood vessels that are causing the most pain in the knee, whether it's on the inside or the outer side of the knee. Inject those little particles to reduce the blood flow and get rid of that abnormal vascularity that forms from the inflammation, and that then improves pain. So for all of these procedures, people go home the same day. This is an outpatient procedure. There's no overnight stay, no hospitalization. I do it in an office-based setting. You spend about 2 hours with us for bed rest time, and then you walk out of the clinic. After the procedure, there's generally not too much needed as far as pain medication. Most people don't require narcotics or anything. They might be on an NSAID medication for a couple of days after the procedure, just to take as needed for any discomfort. And I'll generally have a 1-month follow-up with patients, because it does take a little bit of time for symptoms to gradually improve. So we'll reassess things at the 1-month visit and kind of see how patients are doing. So a lot of the common questions that I get is, how long are these procedures and are they painful? So typically these procedures are about 60 to maybe 90 minutes in time. There's the 2 hours of recovery after the procedure as well. And it really should not be too terribly painful. Before I get into the blood vessel through that small puncture hole, I do give a numbing shot in the skin. That feels like a big bee sting. It's a sting and a burn for about 20 seconds. And then once I get that little catheter inside the blood vessels, luckily there's no nerve endings inside the blood vessels, so you actually don't feel me maneuvering around anywhere at all. So these procedures are not too terribly painful. Patients do get kind of like a twilight type of sedation during the procedure, so that's meant to keep you relaxed and comfortable. The recovery process. So, like I said, there's no overnight stay, no hospitalization. Patients walk out of the clinic. You should take it easy for about the first 5 to 7 days. So, I don't like patients to do any heavy lifting, any exercise, or any strenuous or vigorous activity for that much time. But most light activity and regular daily tasks can essentially be resumed about 24 hours later after the procedure. There's generally no major side effects. With the hemorrhoid embolization, there can be a little bit of soreness in the rectal area, which again, medications like Motrin or Tylenol are usually enough to take care of that. With the knee embolization, you can also get a little bit of soreness around the knee for the first couple of days, which again, if you take Motrin or Tylenol, that's usually enough to subside that soreness. With the prostate embolization, there can be some inflammation in the prostate. And that can give you the sensation that you have to use the bathroom a lot, and you may even get like a burning feeling down in the low pelvis or along the penis. And we do send you home with some medications to help with that burning or stinging sensation. Typically, results will be seen as soon as about 2 weeks after the procedure, and they'll gradually improve over about 2 to 4 weeks. So usually within that first month, you're noticing some improvement in symptoms, and it'll even continue beyond that for some time. And we do have several studies supporting these procedures. I referenced a few of them during the hemorrhoid embolization portion. And there's plenty others. And if you would like a consult, we can always discuss those in further detail. And best way to schedule a consult, that's our clinic number. So feel free to give us a call, and we can always set you up to come to the clinic, or even we offer a lot of televisit appointments as well that can be done over the phone. You can also email us at our email address with any additional questions, or to set up a consult as well.
That's great. Thank you, Dr. Razvi. We do have several questions coming in that I've been answering via message, but I did want to do one live that I thought was pretty good. Can you say more about embolization to treat BPH, like the success rate, side effects, and recovery time?
Sure. Yeah. So the general success rate that we've seen and has been reported in the literature as well, it's about close to about 90% success rate at being able to shrink the prostate by 30 to 50%. So that's kind of the metric that we use and try to compare to. And that 30 to 50% size reduction is usually plenty to improve symptoms. What was the rest of that question? Can you say that again?
So side effects and then recovery time.
Okay. So side effects, I touched on them a little bit, but there can be a lot of inflammation in the prostate after this procedure. Anytime we're cutting off a part of the body from blood supply, it's going to get kind of angry and inflamed. And again, that inflammation generally manifests as this strong urge to use the bathroom. You'll be going often. And you could get like a burning feeling kind of in the low pelvis or along the penis. It kind of feels similar to having like a urinary tract infection, if anyone has ever experienced that. Now, like I said, we send patients home on several medications that help reduce this inflammation and improve these symptoms. We also send patients on an antibiotic to limit any chance of developing an infection. And generally, those symptoms will resolve after about 5 to 7 days or so. And then from then on, the prostate will shrink, and your symptoms will kind of gradually get better, over several months. Now, the recovery time is pretty similar to the other procedures as well. So you'll walk out of the clinic. I usually tell people to take it easy for that first day when they get home. The next day, 24 hours later, most of their light activity they can resume. So they can drive. They can go up and down stairs. They can walk around, do their regular activities of daily living. The things I want people to avoid for about 5 to 7 days, about a week, is to avoid heavy lifting, anything heavier than about 10 to 15 pounds, vigorous activity, strenuous activity, exercise should all be avoided for about that first week. And then the overall recovery. So like I said, the prostate will kind of start shrinking about 1 to 2 weeks after the procedure, and it's going to shrink gradually over the course of about 3 to 4 months. So it's really around the close to the 4 month mark that you get the full effect of the treatment with that maximal shrinkage, which could be about 30 to 50% size reduction of the prostate. But during that time interval, the symptoms will continue to get better gradually.
Great. And then one more question is how basically, obviously, we're not eliminating all of the blood flow to the prostate, as it's a very vascular organ and it continues to receive blood flow. But with that blood flow that it does continue to receive, do the symptoms eventually reappear since it's still continuing to receive blood?
Right. Yeah. So it's pretty common with pretty much all prostate surgeries that symptoms will eventually come back. And the reason for that is, so two things. So unless you're going to go in and surgically remove the entire prostate, which is a very, invasive surgery with a long recovery time, and a lot of times reserved for patients that have prostate cancer, as opposed to just a benign enlargement. Anytime there's some prostate tissue still remaining there, it's going to continue to grow over time because it is a progressive disease. So I mentioned that about 30 to 50% of the prostate is reduced in size. That means 50 to 70% is still there, and whatever's remaining of the prostate will continue to grow. We typically see on average that this procedure will give relief for about 5 to 7 years. That's kind of the average and the range that we see most people fall in. But down the line, it is possible that symptoms can come back, and whatever's remaining of the prostate will continue to get blood supply and will continue to grow. Now, a benefit of this procedure is that it is repeatable. So, 5, 6, 7 years down the line, if you develop symptoms again, we can bring you back in, do it again, further reduce the blood flow to shrink the prostate more, and essentially prolong that time interval.
And then maybe the last question we'll take, is there any chance, because this was asked a couple of times, and great questions, by the way, is there any chance of the particles migrating elsewhere in the body?
Yeah, so those particles should not migrate in the sense that they're not going to go from the prostate up to the heart or the brain and cause an issue or anything like that. And they're small enough that once they're lodged deep into the blood vessels at like a microscopic level, deep in the prostate tissue, that they're really not going to move anywhere else. Now, as they're being injected, sometimes there are little collateral pathways between the prostate and other areas down in the pelvis. So there can be some local effect on other areas that are next to the prostate. So that it mainly includes the rectum, the bladder, and the penis and reproductive structures. So vast majority of the time, if there's any effect of the treatment on these areas, it doesn't really amount to anything that's clinically significant. In fact, you won't even know or realize that any of these areas have been affected by the treatment. Sometimes it can manifest as having some blood in the stool, in the urine, or in the semen or ejaculate. That is possible after the procedure. And if that happens, it tends to be self-limiting and transient. It'll just resolve and clear up on its own with some time. Now, if I see an obvious connection between the prostate and other areas, then I can a lot of times shut off that connection with that small coil and basically prevent or protect those other areas from the treatment.
That's great. Thank you. I'm just trying to see if there's any other questions here. And then I guess maybe this will take this as the last question regarding BPH. Would this procedure affect reproductive function of the prostate, erectile function as well?
Yeah, so one of the benefits of this procedure, and one reason a lot of people like it over a lot of other alternatives to prostate surgery, is that it is a sexually preserving procedure. So it should not have any effect on erectile function, and ejaculatory function should be intact as well. There's a minority of patients that have sometimes reported like the dry ejaculation or where nothing comes out when you ejaculate. With this particular procedure, it's a temporary phenomenon. So it's not permanent the way it is with other prostate procedures. It may be there for a month or two, and then that function does return. Other patients have noted that there's a little bit of a decrease in the volume of the ejaculate, so that's possible, but overall sexual function is preserved with this procedure.
Great. So I think, let me see, lots of questions, which is great. And a lot of these questions, if we don't get to everybody's question tonight, please feel free to either email in, or please, a lot of these questions can honestly be answered by a consult with your urologist, especially for those that are asking about other procedures. I would strongly recommend having an appointment with your urologist in regards to treatment options, BPH versus Urolift, or if you've already received a Urolift, if PAE is an option, gland size. All of these are great questions to ask your urologist. We're not really here to diagnose anybody or, recommend PAE for everybody. This is one option amongst many options that your urologist and Dr. Razvi can offer. So we're not here to consult with anybody or give anybody medical advice. We just want to inform people of the options that are out there. So for those of you who have more specific options, I really highly encourage you to either reach out to your urologist, or you can schedule a consult with Dr. Razvi as well. His information is on the screen. I would highly recommend for you to reach out to him as well. So with that being said, I think we're going to conclude for this evening. I really appreciate everybody joining. If anybody, as I mentioned, for further questions, please don't hesitate to either reach out to Dr. Razvi at the email on the screen, or with your urologist. So with that, thank you very much. And that concludes this evening. Have a good night, everyone.
Thank you. Have a good night, everyone.